All right, I'm gonna go ahead and get started. The first one is case of Dr. Yurikov. This is a 60-year-old male with a 1 week history of gait imbalance, bilateral lower extremity weakness. Reports some unsteadiness with gait. Has sensations of like heat and cold in both legs. This is the neurological exam, and the approximately 2 out of 5 strength, distally 1 out of 5. 3+ patellar reflexes, positive clonus. So let's see who's not. I guess Turkey, in terms of the next steps, what would you do?
Yeah, so this is it seems like a myelopathy signs and symptoms presentation, localization to the thoracic spine, given that only lower extremities are involved. So I would do imaging. I would do MRI first, of the thoracic spine, and also CT of the
Okay,
T-spine.
awesome. So here's the CT. What can you see here?
Yeah, so yeah, I think this is T4, T5 level. So there's like lucency of the T4, T5 vertebral bodies also extends to the posterior column or elements, given that the pedicle of T4 is involved. Um, um, so differential diagnosis, I would like to see an MRI first,
Yeah.
but given that there's, yeah, yeah.
And then anything, I guess, interesting you notice on this MRI scan? Uh,
Yeah, on a T2, sag and axial, it's hyperintense lesion with vertebral body involvement, also collapse of the T5 vertebral body, and also involves the spinous process.
yeah,
Interestingly.
and there are a lot of these like small like T2 collections within it. This is the contrasted MRI.
Got
Uh,
it.
Obviously contrast enhancing here. So I guess in terms of your differential diagnosis, what would you kind of consider for this?
Given that this is an extradural lesion, number one could be metastatic disease. Could be also primary bone disease, such as giant cell tumor, given the enhancements.
Yeah, exactly. I'll go a little bit more over this differential in a later case, because actually this one is actually a pretty rare tumor, but so I'll jump a little bit more to that, but I'll go over some of these, I think in case 3. So let me just bring up the pathology slides here. All right. So
Good morning.
yeah.
Um,
So yeah, this is the phosphaturic mesenchymal.
right. Let me make the screen a little bit. Okay, so on let's go to the first picture.
Mm-hmm.
Yeah. You're not on the first picture, right?
I think this is like the first image of the 4 here. Like,
okay.
Yeah.
So, well, on the left, if you don't move them, I can maybe talk about it.
Yeah, sure. I'll put them full screen.
Okay.
All right.
Yeah. The way I see it is the images on the left are not on my screen. For some
Let me
reason.
try one other thing. How about, is that a little bit better?
Yeah, I see the SAT-B2 and the top HNE. Yeah, go that way. Exactly. On the left. No, the other way.
Oh, I'm actually not moving it. It's weird that it's
Oh, that's interesting. Okay. So on the left, there is a cellular tumor from low power with some hemosiderin deposits that are like rusty brown, again, on the left side. The bottom picture on the left shows some myxoid stroma. The top on the right shows some dilated blood vessels and, fairly cellular neoplastic proliferation. Now, this is a difficult diagnosis. This could have represented a hemangiopericytoma or some other bone neoplasm. But Dr. Rosenberg, our bone and soft tissue pathologist, worked on this case pretty diligently, as he always does, and he discovered that the tissue is not only reminiscent of that diagnosis on H&E, but also expresses a marker called SATB2. It's a nuclear marker you see at the bottom, and negative with pretty much everything else, including hemangiopericytoma markers. So he suggested the diagnosis of phosphaturic mesenchymal tumor, which is, again, pretty rare. Most of us just read that in the books. As pathologists, we rarely see one in the professional lifetime. So I'll allow you to elaborate on the diagnosis.
Sounds good. Okay. Before I go in, I'll quickly go over the surgical approach. Sumedh, are you there?
Hey, yeah, I'm here.
Okay, cool. Can you see my whole slide, or is it just part of it again?
I can see most of it, yeah.
Okay. So for this tumor, how would you approach it?
Yeah, I think based off of the location, based off of its kind of involvement, what it looked like on at least CT scan, there was the lytic portion of it and the pedicle, the body of the actual vertebrae, encompassing most of the lamina, most of the vertebrae itself. I think at that T5 level, I think at this point you'd have to, consider removing the entirety of the vertebrae, just because, it sounds like this entity probably should be resected in full. I think that you can do a transpedicular decompression and corpectomy at this level just to try to get as much of that out, and then you'd have to maybe fuse them two up, two below.
Nice. Yep. So that's essentially what was done. Exposed T2 to 8. The screws could be put in on the right side at T4, and then bilaterally T3, 6, and 7. But like you said, T4, 5, laminectomy, transpedicular decompression, corpectomy at that level. And then in terms of actually putting in the cage, by taking a little bit of the rib head along with the T5 nerve root, in moving the T5 nerve root, you can slide in the cage posterolaterally. So these are the images. They look good. So just a little bit about this, extremely rare, less than 500 cases reported in the literature. So most common presentation is actually not so much pain, but related to hypophosphatemia or osteomalacia, which leads to muscle aches, kind of generalized weakness, bone pain, multiple fractures, not only at that tumor site, but other places as well. And the way this works is the tumor cells produce FGF23, which decreases renal absorption of phosphate, and then basically inhibits the production of activated vitamin D. Typically occurs in middle-aged adults, and most patients typically present with gradual muscle weakness, diffuse bone pain, pathologic fracture. And because it's not, the presentation isn't necessarily localized to where the tumor is. A lot of times the diagnosis is delayed. Most of the time, if general labs are done, it shows hypophosphatemia, phosphaturia, and then low levels of hydroxyvitamin D3, which are expected to be elevated in someone with hypophosphatemia. The tumors themselves are benign spindle cell neoplasms. The most common morphologic subtype is the mixed subtype. There's also osteoblastoma-like and other things. They typically originate at a site of bone or soft tissue. And as we saw, the MRI shows quite a bit of T2 hyperintensity, especially in that kind of patchy distribution. It's iso-intense on non-contrast T1. Doesn't have very strong contrast enhancement like some metastatic tumors do, but more homogeneous. If you can't really tell on MRI, but you have very high suspicion for these based on the labs, you can do something called somatostatin receptor imaging, which will localize the tumor. And resection of the tumor will be curative, and then we'll treat the secondary osteomalacia. Case 2, let me see who's on here. Adam, are you here?
Yeah, I'm here.
Okay, great. So this is a 48-year-old lady with 6 weeks of progressive worsening of the left leg pain. It's along the posterior aspect of the left leg, down from the buttock into the posterior thigh, posterior calf, into the side of the foot. She tried with an L5-S1 discectomy 14 years ago and then 3 years ago. Despite this, or maybe because of this, she's had constant numbness and intermittent weakness in the left leg since the first surgery. The pain's worse when walking, distance from the gait to about 30 minutes, improved with sitting, no bowel bladder issues. She's taking gabapentin, doesn't really feel like it's giving her much relief. She's neurologically intact on exam. What would you do for your next steps?
So in terms, I would also want to include thoracic spine, lumbar spine, and I would start with the CTs and then go afterwards for MRIs with and without contrast.
Awesome. So on the MRI lumbar spine, you actually, if you go down a little bit lower, you can see this thing here. So can you tell me what this looks like?
This is on the. I see the CT. Did you open the MRI?
No, sorry, just the CT because they're on different slides, but at least on CT scan in terms of.
So you see here on the CT, there's this mass at the L5 S1 level. It's most likely. It looks like there might be some extension into the canal, but otherwise it looks like a single lesion mostly.
Yeah, it looks like maybe expanded out the foramen. You can see you can see the nerve root, the S2 nerve root on the other side. S1, is that that on the coronal, you can see that bone up top, right above the tumor. So probably like S2, S3 nerve root, which we can see a little bit better on the MRI scan here. So what's it look like there?
So you're looking at the T2 MRI sequence. You have a cystic component, large cystic component in that lesion that's coming out of the nerve root, probably on that left side.
Yeah, it looks like it's probably rising from, it looks like S2, the S2 nerve root, and T2 hyperintense, probably cystic. The rim is contrast enhancing, as you can see here. This is another nice coronal view. You can't really see the sciatic nerve here, but it kind of comes off distally from it. So what would your differential diagnosis be here?
I would think about nerve sheath tumors. I would think about schwannomas, neurofibromas would be the highest two on my differential for nerve sheath tumors.
Awesome. Yeah, there are a couple other differentials as well, but yeah, good job. That's probably the most common ones. Let me pull up the pathology slides.
So this is a peripheral nerve sheath tumor, benign. You can see in this picture that there's a very thick capsule, which is typically present in schwannomas, and you can see some hypocellular tumor parenchyma. Well, again, I don't really see the whole green here, so maybe, do you think, yeah, you can move up like that? I can see the second picture, or okay, so you can see here a collagenous stroma and a spindle cell proliferation. At the bottom, you can see that high power, that the spindle cells look kind of innocuous. They don't have mitoses. It's not super high cellular. There's hyalinization. So, it looks like either a schwannoma or a neurofibroma, but when you do collagen 4, it looks like cells. Every cell has labeling, which means there is basement membrane. That means it's Schwann cells. Also, cells stain with S100 and SOX10 pretty uniformly. And in the neurofilament, you can see that most of the axons on the right upper corner are at the periphery of the tumor. So those attributes are more those of a schwannoma. So the final diagnosis is schwannoma, WHO grade 1, with some unusual morphology.
Awesome. I think the screen is actually following my mouse around. That's why it maybe looks like it's moving. So if I'm not at the right picture, I'll just move my mouse over the right picture. Let me go back to my slides now. All right, cool. So Victor, are you on?
Yeah.
Oh, cool. So in terms of the surgical approach, how would you do this?
If you could just quickly show up the images again. I think based on this location, you could come from it from the front. Or naturally, you could also come from it from the back, but you could favor a forward approach similar to like an ALIF approach, including and if you and consider the fusion itself if you consider it unstable after resection.
Yeah, I think probably would likely not be unstable, just because it's in lower down, next to the sacrum. But you're right about the ALIF exposure. So we use general surgery for the retroperitoneal exposure. Very similar to an ALIF approach, just lower into the left lower quadrant, and in the presacral area, same retractors placed. And just by putting the retractors, this lesion was pretty big, so you could see the ventral surface. And obviously, it's rising from a nerve root. We just stimulated, make sure there was no activity, coagulated the capsule, separated it, identified the true tumor wall, dissected the tumor wall away from the capsule, decompressed the cyst to make it a little bit easier for us to take it out. So schwannomas, of course, arise from Schwann cells. Characteristically, they have this circumscribed mass with a well-formed collagen capsule and hyalinized vessels. And on histology, as we discussed, you have two distinct areas. You have the Antoni A areas, which are compact and it's hypercellular with these spindles. Antoni B, which are more hypocellular, microcystic, abundant collagen and macrophages. In immunohistochemistry staining, you have diffuse, strong expression of S100, pericellular collagen type 4, with the continuous pericellular basal lamina as Dr. Gutov can mention. You have a GFAP, which is positive in a subset of schwannomas. You can have some other positive staining as well. So I know, we've talked about schwannomas in the past, so I didn't want to go over the same topic, so I thought I would do something a little bit different. There are 4 different types of schwannoma variants, so I just, I'll go over each of those briefly here. So the four most common subtypes are cellular, plexiform, melanotic, and reticular. So cellular schwannomas have high cellularity, a fascicular growth pattern, high mitotic activity. Less than 10% are composed of that Antoni B growth pattern. They don't have Verroque bodies. They can be locally destructive, have bony erosion. Sometimes on radiographic imaging, they can be similar to malignant peripheral nerve sheath tumor, but you can distinguish the two with S100 expression. They typically don't have malignant, potential transformation. They don't metastasize. But because of their high, their aggressiveness, they have higher rates of local recurrence. Plexiform schwannoma typically occurs in the cutaneous or subcutaneous location. And kind of like plexiform neurofibromas, the pattern of growth is in this intraneural nodular pattern. About 5% of cases are associated with NF2 or schwannomatosis, and those are primarily composed of Antoni A histology as well. Melanotic schwannoma is more rare. They can have malignant potential. On histology, you see epithelioid cells, variable nuclei, accumulation of melanin and neoplastic cells, they may be associated with Simoa bodies as well. And So I'll go to the next one. Those are the most three common types. Let's see if we can still check this on. Tyler, are you on?
Yeah, I'm here.
All right, cool. So this next one's a 51-year-old guy with a 20+ pack year smoking history. Now with a 1 month history of thoracic back pain, worse over the last 1 week, along with subjective gait instability, no weakness. Also has these newly diagnosed pulmonary nodules in this adrenal mass. On his exam, he's fully intact. What would you do for your next steps?
Probably both find MRI at that point, just because you're suspecting metastatic disease.
Awesome. So this is what the MRI looks like.
Okay, yeah, so let's say, so T4, it's like in the vertebral body, likely a metastasis with retropulsion into the canal with, I can't tell if there's port signal change, but definitely severe stenosis at that level.
Yeah. You can see there's some contrast enhancement. Mm-hmm. And so what do you think for your differential?
So, I mean, top my differential given known cancer history, well, I guess suspected cancer history is metastatic disease. And then, of course, given it's in the bone, it could be primary bone tumors as well, or lymphoma.
Yeah, so metastatic disease, myeloma, primary bone tumors, infection can sometimes present like this. There are obviously different forms, osteoblastic, osteolytic, that I've gone over before. Most common osteoblastic tumors, prostate cancer, medullary thyroid carcinoma, osteolytic, most of the other ones. Let me pull up the pathology slides here.
So this is a straightforward pathology diagnosis. On low power, you see an infiltration of atypical cells. And on the right side, you can discern on high power that these cells have a considerable amount of nuclear atypia, prominent nucleoli, again, an infiltrated pattern. And then at the bottom, I'm just showing you one of the immunohistochemical stains, TTF1, which is characteristically nuclear positive in these cells. And the lung pathologist who looked at this decided that this is the most compatible with a lung primary, metastatic adenocarcinoma.
Yep, so this one pretty straightforward. I just want to talk about some of the grading schemes that we use for these, as well as some of the surgical considerations. David, are you on?
Yeah, I'm here.
Okay, awesome. So just in general with these metastatic tumors, like what kinds of things do you take into account when it comes to deciding surgery versus no surgery?
So in this particular case, you want to consider doing a supplementation surgery so you can have adjuvant radiation afterwards. Obviously, you want tissue biopsy as well. And if there's associated with it, you want to decompress the spinal cord.
Mm-hmm. Yep. So neurological deficit, if we need to decompress the cord, and then radiographically, how much cord compression is there? Is there a need for separation surgery? And in the same vein, what's the radiosensitivity of the tumor, and how will that factor in post-operative radiation planning? And then is there any instability either from the tumor itself or from the surgery that will be needed to treat this? And then obviously involvement of any vascular structures, any other nearby critical structures. And so for this one, how would you approach it?
Yeah, for something like this, I would approach it like doing a transperineal decompression. It looked like the tumor caused a good amount of circumferential encasement, so it could do like bilateral transperineal decompressions and then instrumented fusion 2 levels above, 2 levels below.
Awesome. Yeah, so T4 bilateral transpedicular, confirm with the ultrasound to make sure that the decompression is adequate. And then, 2 above, 2 below. So, I'll talk about some of the criteria that we use to, grade this in terms of the fusion and some of the NOMS framework and all that stuff in a little bit. But just briefly about metastases, about 10% of newly diagnosed cancers have vertebral metastases, more common in older patients, as would be expected. Most commonly found in the thoracic spine, not as common in the lumbar spine, much more rare in the cervical spine. Spares the disc space. Most common seeding is through Batts and plexus. The blood supply to the metastatic nidus, once the tumor is seeded and grows, typically comes from the pedicular arteries. And postoperative radiation, overall, generally, typically involves like 3 to 4 gray across, per session across 10 sessions. So we're talking about instability. So the SIN score is one method, that has been used to assess whether these tumors are unstable or not. Takes into account, I mean, this is not, by any means, definitive, but it's just kind of an overall framework that can be sometimes used to help decision making, if there's a question. But it takes into account where the location is. If it's, a junctional and mobile segment versus a rigid segment, like, the middle of the thoracic spine, if they have mechanical pain, what the radiographic characteristics look like. Is it lytic or is it blastic? What the spinal alignment looks like, how much the vertebral body has collapsed. And again, they label these as unstable, potentially unstable, stable, but it's just one framework, one scoring guide that can be used in terms of deciding, how to approach whether to fuse these or not. And then, as I talked about before, the NOMS framework takes into account the oncologic, neurologic, mechanical, and systemic considerations. And what it does is it basically is a decision tree to figure out, what needs to be done in terms of stabilization, external beam radiation, SRS, whether decompression is needed or not. So, okay. And then the last case, let me see, Imad, are you on?
Yeah, I'm here.
So this is a 71-year-old guy with left arm paresthesias for 2 years. He's had carpal tunnel surgery on the left hand, no relief. After surgery, he noticed left hand numbness, difficulty closing his hand, dropping objects, and also gait balance. On exam, he's fully intact except for left iliopsoas is 4+ out of 5 strength. He's got decreased sensation in the left hand. He's a brisk bilateral Hoffman's. So what would you do?
Sounds like he's having some symptoms of myelopathy. I would get a cervical spine MRI.
So this is what it looks like.
Yeah, so he, okay, yeah, so it looks like he has a pretty well circumscribed contrast enhancing mass at the level of C2 with kind of abutting the spinal cord. I think I see like a dural tail at the inferior shoulder. I mean, the first thing on my differential would be this looks extra, looks intradural, extramedullary. So I would think maybe like either like a meningioma given its contrast enhancement, but like peripheral nerve sheath tumors will probably also be on my differential. But given the enhancement, it looks like a meningioma.
Yep. Let me pull up the slide.
So again, low power shows moderately cellular tumor. At the bottom of the left set, you can see that the cells are low grade and forming whorls and nests with some pseudo inclusions. I don't see the bottom of the slide, so I'll go to the immunohistochemical stains. It's uniformly progesterone receptor positive, which happens in meningiomas, and the Ki67 is low. So meningioma WHO grade 1.
All right, David, are you still on?
Yeah, I'm here.
Okay, cool. So I guess with a tumor of this size and this location, how would you approach it?
Yeah, so For something like this, given how high up it is, anterior approach would be pretty difficult. I would consider doing like a laminectomy, maybe a perimedian dural incision, and then approaching it from posteriorly.
Yeah, perfect. So yeah, C1 to 3 laminectomy, because the tumor is kind of pushing the spinal cord over to the right side, you can do a perimedian durotomy closer to the left side. Because it's so big, it's tough to separate it from the cord without causing issues. So debulk it with the sonopet and then slowly roll it away for the spinal cord for the resection, and then bipolar the dura at the origin of the tumor. So these account for 25% of all intradural extramedullary tumors, and spinal meningiomas themselves account for about 1 to 10% of all meningiomas. They're most commonly found in the thoracic spine, 15% are in the cervical, and about 2% are in the lumbar. The most common risk factor is high-dose ionizing radiation earlier in childhood, and these are most commonly seen in elderly patients. Peak age is about 60 to 70. Male to female ratio is about 1 to 4, but interestingly, in lumbar meningiomas, it's about 1 to 1. The most common initial presenting symptom is local pain. They can be seen in young patients in the context of NF2, and those patients have aggressive histological subtypes. Most meningiomas are benign. WHO grade 1 meningiomas account for about 70 to 90%. The subtypes with WHO grade 1 meningiomas are the meningothelial, Samoides, fibroblastic, and secretory meningiomas. The meningothelial subtype accounts for about 80% of all WHO grade spinal meningiomas. WHO grade 2 is about 5 to 25%. Clear cell meningiomas are one of these. They typically come from the dentate ligament, and then the least common is WHO grade 3 meningiomas. So most spinal meningiomas, so about 90% are intradural extramedullary. About 5% are purely extradural, and these are more aggressive, and 5% are both intradural and extradural. So after complete resection, leaving the dura, bipolaring the dura, the recurrence rate is still about 7%, and the average time for recurrence is really typically between 4 years and 17 years. As we talked about, the classic histological characteristics, they're packed together in whorls, fascicles, and syncytia. They have Samoan bodies, and it's positive for EMA and SSRT2. Okay, and I just want to end a little bit early because I know we had that extra presentation from Ian. So I'll let Ian take over now.
Thank you, Vinesh.
Can everyone hear me okay?
Yes, we can hear you fine.
All right, hello. So my name is Ian Ramsey. I'm a third-year medical student here on my sub-I, applying for neurosurgery this fall. And the title of my talk is the use of big data to assess neurosurgical trends and outcomes during the COVID-19 pandemic. So a little bit about myself. I grew up in Maine, went to college in Maine, and did some MRI contrast research before medical school. And so when I got to medical school, it was in the middle of the pandemic, which had significant restrictions on what we can do. And as a student interested in neurosurgery, that was a little bit limiting. But I was very fortunate to get in contact with Evan, and we started doing some research using the nationwide inpatient database. And this is a database that is good for national estimates, and it's a stratified sampling of all inpatient patients in the United States that can be used for making both regional and nationwide estimates on things like utilization of care, access, costs, quality, and outcomes. And the database contains information, demographic information, ICD-10 diagnostic and procedure codes, and some basic outcomes like inpatient mortality, and discharge disposition. So my talk will be an overview of how we've used this to assess some trends during the COVID-19 pandemic as it relates to neurosurgery. So the first project I want to talk about is outcomes in patients with large vessel occlusion strokes undergoing thrombectomy that who have current COVID-19. And so COVID-19 has been associated with stroke, and preliminary data shows that patients with LVOs that undergo thrombectomy when they have COVID have worse outcomes, but it's very preliminary data. And so we use the NIS to further evaluate this. And so what we did is there's no specific diagnosis code for large vessel occlusion stroke. So we defined it as they had a concurrent ICD-10 code for ischemic stroke, and then also a procedure code for mechanical thrombectomy. And we excluded patients with codes for multiple vessels because it wasn't, we wanted to take that out. And so what we found, there's about 17,000 total patients during 2020. Only 380 had a co-diagnosis of COVID-19. The cohort with COVID-19 was a little bit younger, about 5 years younger, around 64 years. And they had higher rates of diabetes and coagulopathies, but lower rates of some of the more traditional risk factors for stroke, like hypertension, coronary artery disease, and the like. And strikingly, what we found is that 22.4% of patients with COVID-19 that underwent thrombectomy died versus only about 10 in the non-COVID-19 cohorts. And so the odds ratio multivariate for death for the COVID-19 patients was almost 3, and they had a lower odds of routine discharge at 0.65 as well. And as you can see in this figure, medical complications for these patients were higher with COVID-19 for respiratory failure, pneumonia, PE, DVT, MI, and the like, but a rate of subsequent cerebral hemorrhage was insignificant, and there's insufficient data, but also iatrogenic stroke was lower as well. I'm sorry, it was insignificantly different. And for invasive supportive measures, lower odds of PEG for COVID-19 patients, and perhaps as expected in COVID-19 patients, higher odds of mechanical ventilation. So what we conclude is that there's greater mortality and lower chance of routine discharge in these patients. And we believe, although we can't say for sure, that possibly the worst outcomes are actually due to extracranial manifestations, given the higher rates of medical complications in the context of what we don't think there's worse kind of like stroke specific complications in the COVID-19 patients. So the second topic I just want to briefly go over is the impact of the COVID-19 pandemic on treatment outcomes of cerebral AVMs. And so the treatment of AVMs is a little bit controversial, but most specialists, to my understanding, prefer intervention to reduce risk of future hemorrhage. And a great paper published here by Evan and Dr. Stark and team showed that as there's been a decrease in interventions for unruptured AVMs, there's a corresponding higher rupture risk, which of course is association, not causal, but certainly interesting. And so we just assessed how have the interventions and outcomes for patients with AVM changed in 2020 during the first year of the pandemic. And so again, we used the NIS database, and we defined ruptured AVM as an ICD-10 code for AVM plus either ICD-10 code for intracerebral or subarachnoid hemorrhage. And we compared the patients in 2020 to 2016 to 2019. And so we found, there's about 65,000 patients and 22 and a half, sorry, this is from 2016 to 2020, 22.5% had a ruptured AVM. And the rupture rate in 2020 was higher, about 24 versus 22 between 2016 and 2019. And the intervention rate in 2020 was also much less, 13.3 versus about 18% over the 4 preceding years. And the odds ratio for intervention was 0.69, which was for 2020, which was statistically significant. And so this is just a graphical representation. You see in 2020, the rupture rate goes up, the intervention rate goes down. And we also looked at the types of treatment that patients were receiving. So on the left panel, you see that there's a slight decrease in endovascular therapy. But importantly, combined endovascular therapy and surgery increased, and then SRS only increased, radiosurgery rather, for unruptured AVMs. And lastly, we see that there's really a monotonic increase from 2016 in rupture rate, and also monotonic decrease in intervention rate. But you see that in 2020, there's like this kind of inflection. And we did a linear regression to correspond, intervention rate and rupture rate, and the association between, and that was statistically significant with an R squared of about 0.88. So conclusions, right? There was a decrease in treatment of unruptured AVMs in 2020, and the rupture rate increased. And in terms of the ways that these were treated, we think that possibly, although it's speculative, maybe dual endovascular and surgery increased, in that sometimes this is done over 2 hospitalizations, but to decrease time spent in a hospital because of the pandemic, possibly they received both in 1 hospitalization. And also that maybe SRS increased because this is something where someone doesn't necessarily have to be hospitalized, or certainly not for extended times. So lastly, I just want to touch on the effect of the pandemic on pituitary surgeries. So during the beginning of 2020, there's a shift away from transfinital pituitary resections, because it was believed that these nasal procedures, endonasal procedures, might facilitate the spread of COVID-19. And so we just looked at the trends, and we used the NIS database. We queried patients from 2017 to 2020, and compared the prior years to 2020. And so what we found actually is that the intervention rate did go down a slight bit, but the proportion of transfinital surgeries actually increased in 2020. However, when we analyze it on a month-by-month basis, in April, as you see on the right, the proportion of transfinital went down quite a bit, and then transcranial increased, despite overall in 2020 it being increased. And so also we looked at outcomes, and there was no significant difference in death when patients were treated in 2020 to the prior years, but slight increases in any kind of complication, neurosurgical complications, but no difference in medical complications or supportive measures. And again, this is just a month-to-month analysis of the outcomes. And so the key finding is that, routine discharge went down. Any complication, neurosurgical complications and medical complications actually went up around April. And a little bit before that, the need for invasive supportive measures went up. So 2020, the proportion of transfinital surgeries actually increased, but in April, we did see that there was a decrease prior to past reports, and this was transient, and outcomes were slightly worse in 2020. So limitations of the NIS overall, it lacks many clinically relevant variables and information about hospital course, and you can't necessarily have a great temporal resolution of the events occurring from the ICD-10 codes. And also you don't get long-term outcomes. It's really only outcomes at discharge. And so the NIS can often provide an overview of trends in neurosurgery, and can provide some data about outcomes during hospitalization. Here are some citations. I just want to, neurosurgery, as I've learned, of course, is very much a team effort, and same with research. And I'm so indebted to all of the faculty, residents, and medical students that I've worked with on these projects. But especially Evan Luther. He has been an incredible mentor to me, and I'm extremely grateful to have met him. And he has just invested so much time in teaching me, and I'm super grateful for that. So thank you, Evan. And if anyone has any questions, I'm happy to answer them.
Hey, Ian, it's Evan. I was just going to say, great job. I think, just wanted to comment that, the importance of what happened with you and you kind of in your story about coming into medical school at the beginning of the pandemic and not really having a lot of opportunity to engage in clinical stuff here. And I think you really kind of spearheaded and championed a lot of these projects, and you're an MD MPH as well, so you're kind of at a regional campus, which I think puts you at a little bit of a disadvantage of like getting to know the department and people here. But I think it was this using this kind of big data stuff really helped you kind of continue to like further your research efforts despite not being near us all the time. So anyways, great job and thanks again.
Thank you. I appreciate it, Evan.
Evan, where do you see the future of the national inpatient sample going? Do you think we're kind of maxed out with publications on it, or do you think there's like kind of a future for more work on in the frontier? Maybe if Ian or Evan, if you want to answer that.
Sure. I think, to be quite honest with you, I mean, obviously, I've used this thing for forever, but I think that the most impactful publications or findings in this is definitely about trends, in surgery. And I think, for me personally, like one of my favorite papers that we had published was, looking at trends in AVM treatments after the, Aruba study to see how Aruba had really affected the treatment of AVM. So I think in my mind, that's what NIS is good for. The outcomes, the initial outcomes stuff, it's hard to say because it's not really long-term, evaluation. There's been some kind of, the HCUP, which is the people who organize NIS, have been working towards trying to find something more like robust to have long-term outcomes, in terms of readmission rates and things like that to follow these same patients. But it's not great. So I think to answer your question, that I think the best answer is that this database specifically is helpful for evaluating trends, especially if you're looking at trends after a big event. So I think Ian's kind of the idea here was to look at how COVID-19 changed things, and obviously you can see that for a number of different things like transfemoidal surgery or strokes, COVID-19 had a pretty significant impact on how things were treated during that year. And I think hopefully in the future as well.
Perfect. Awesome. Okay, guys, I have a lot to go over today. I'm going to go over pyogenic spondylolischitis and the spinal epidural abscess, its history and controversy. So I feel like we get a lot of these consults at Jackson, especially. And I know as a junior resident, this was something that always I found confusing in terms of what the right answer was to the infectious disease doctors or the hospitalists. They're constantly hounding you, asking you, when are you going to operate? When are you going to operate? And I hope this helps clarify a lot of questions that I definitely had as a junior resident. Sorry, 1 second. Hello? Good. No, I'm actually I'm at home. Yeah, I'll be there. Nothing. Yeah, sure, no problem. Yeah. Yes, absolutely. No, absolutely. Yeah, no, I know. No, I know. Very much so. Very much so. Yeah, I know I am. Thanks. Yeah, sure, absolutely. Yeah, absolutely. Yeah. Awesome. Thanks for joining. Thanks. All right, sorry guys. Speaking of Dr. Wang, apologies. So we're going to go over the definition, history, epidemiology, pathophys, everything you see listed here. I have a lot to discuss, so we're going to try to get to it quickly so we can get everyone out of here. So in terms of the definition of spondylodiscitis, it's kind of a continuum you see on this table. It kind of progresses from an infection that's can be isolated to the disc space, most often seen in children due to the vascularity of the disc. And that can progress into spondylitis, spondylodiscitis, and then primary and secondary epidural abscess, which can form kind of as a contiguous spread of the infection. Just advance forward. So in terms of spinal infections, they can be broadly classified. They can be pyogenic, which is what I'll be focusing on. They can be granulomatous. So this can include tubercular, brucellar, or fungal infections. That's a whole talk in and of itself. So, and I won't really be touching on that. We're going to mainly be focusing on pyogenic organisms, and finally parasitic infections, which typically we don't see here in the US, typically are seen in the developing world. Now, in terms of the historical background, the spinal epidural abscess itself was first described by an Italian anatomist in 1761. It wasn't until 1892 that the first operative intervention was undertaken, and this was by a French physician. The patient, however, did not survive the intervention. In 1901, there was the first report of a successful laminectomy in which the patient survived, and it was after a knife wound to the 8th, 9th thoracic vertebra. And it was finally in the 1920s when Dandy and a few other surgeons were the first to use laminectomy and talk about it intensively as a successful treatment option with, a multi-case series. So in terms of the epidemiology, we'll briefly go over that as well. Pyogenic organisms, typically more prevalent in developed nations, and other etiological agents like TB and fungal organisms typically predominate, as we said, in the developing world. The incidence has gone up over the past 15 to 20 years, and this is, likely due to the fact that we have more advanced diagnostic technology, such as MRI, that's gotten better and better. The intravenous drug use has also been associated with the increased prevalence of spondylodiscitis, as well as the aging population. In terms of the most common isolated organisms, they're typically staph or streptococcus. The organisms can vary, though, depending on the patient's comorbidities. So gram-negative bacteremia is most commonly associated with patients that are immunosuppressed. Other risk factors that can predispose to patients to pyogenic spondylodiscitis can include extremes of age, illnesses or drugs predisposing to immunological compromise, and then obviously septicemia. So now I just want to go over briefly the anatomy that's applicable to spondylodiscitis and epidural abscess. So first, it's important to realize that that contrary to previous belief, the metaphyseal bones and the cartilaginous end plates, being the starting points of infection, is actually the intervertebral disc that's the origin of infection, especially in the pediatric population, where there's extensive anastomotic arterial networks between the vertebral body and the central disc, seen in this figure here. And in view of the excellent anastomoses between the discal and the corporeal vasculature in pediatric patients, direct disc involvement is much more common in children, and children can typically present with fussiness, inability to walk due to pain, different from the adult population. As we get older, but beyond 15 years of age, as we get into our 20s and 30s, the nucleus pulposus becomes avascular, and the disc receives nutrition through diffusion across the end plates. Therefore, in adults, typically septic emboli reach the end arteries and then get trapped in and around the end plates. And typically what happens, this results in local bony infarcts and end plate disruption, osteolysis, and then which can lead to vertebral compression fractures and deformities, and as well as discitis. In terms of the different routes that patients can develop discitis, osteomyelitis, and epidural abscesses from, arterial route is definitely a primary seeding route. However, it is important to realize that our friend Baston's plexus can also be guilty of as being the quote unquote culprit of which bacteria seeded into the patient's spine. And this is due to retrograde seeding of venous blood into the plexus, again, and spreading infection around the spinal canal. In rare cases, the infection may actually spread in a continuous fashion from like the retropharyngeal space into the vertebral body, especially in the cervical spine. Now I want to go over the pathophys. So in terms of the infections that the way in which infection may spread to the spine, as we briefly just discussed, the first is obviously hematogenous spread. Next, most common is direct inoculation from the exterior. So from some sort of intervention, a laminectomy, and an epidural injection. We just had a patient a few weeks ago who presented that way, or direct extension, again, from a contiguous structure. In terms of hematogenous spread, this dissemination can occur from distant sites like, the skin or the GI or the GU tract. And in terms of hematogenous spread, it most commonly goes to the lumbar spine, followed by the thoracic and cervical spines. And hematogenous spread accounts for approximately 50%, so over half of cases of pyogenic vertebral osteomyelitis. And this again occurs because of bacteremia seeding into the avascular regions of the subchondral bone. Next, like I mentioned, is direct inoculation. Again, this is the second most common cause and can occur again after lumbar puncture, epidural block, laminectomy, or other spinal surgery. And then lastly is the extension from, an esophageal perforation or aortic implant or the such. In terms of, the pathophysiology of spinal epidural abscess, as I mentioned, this is all a continuum or progression of disease. And typically spinal epidural abscesses, they're secondary and they occur through direct extension from a patient who had discitis, osteomyelitis. And most cases develop in the, dorsal epidural space. And, once it has developed, it typically is limited to 3 to 4 vertebral segments and most commonly occurs in the thoracic spine. Next, I want to go over the histopathology and kind of the pathogenesis. This is something that has a little bit of controversy. And what I'm talking about is the pathogenesis by which infection in the epidural space leads to a neurological deficit. So there's evidence for both direct compression possibly leading obviously to a neurological deficit, or vascular occlusion, which is a little bit more controversial, which can cause septic thrombophlebitis, and that being the offending mechanism. So this was an interesting paper published in 1989 out of the University of Michigan. This was a combination of neurosurgery and infectious disease, looking at rabbits, which they injected with Staph aureus into the posterior thoracolumbar epidural space. And they found that this model was shown to reproduce both the neurological, bacteriological, and radiological aspects of human disease. So they essentially injected these rabbits with Staph aureus, then compared their normal vascular anatomy to rabbits with mild to moderate to severe cord compression. And they found that animals with severe compression, the anterior epidural venous plexus still remained patent, suggesting that the direct compression model is the more accurate model, and the more likely reason that patients develop neurological deficits from spinal epidural abscess specifically. So this was a nice histopathological slide that they included in their paper. Here you see the anterior spinal artery, posterior spinal artery, the dorsal spinal vein, and this is a normal rabbit, which they use as their control. They then compared that to a rabbit with moderate spinal cord compression by an epidural abscess. And these were in 2 rabbits who suffered from paraplegia from the abscess itself. And they found that when they looked at these specimens, the anterior spinal artery as well as the dorsal spinal vein remained patent. And then they looked at, again, another spinal cord here of a rabbit after the laminectomy had been performed, and then again found that the posterior spinal vessel remained patent. So, there is, however, this other theory that, vascular thrombophlebitis leads to a neurological deficit in these patients. And here's one paper that was published in 2004. They published 2 case reports, or 2 patients in whom neurological signs were found to be caused by spinal cord ischemia due to thrombosis of these leptomeningeal vessels. So, I think probably both factors are involved in the development of neurological injury, and both definitely play a role in why patients develop weakness secondary to this devastating disease. So now, in terms of the clinical manifestations of this continuum, I found this interesting paper. This is, a kind of a milestone paper that was published in 1948 by Dr. Huesner. He was a neurologist at Boston City Hospital associated with Harvard Medical School. And he was kind of ahead of his time. He was one of the first people to really go delve into a case series of spinal epidural abscess. And he was one of the first to point out that, you can see in these last few lines, the illness is almost routinely mistaken for some everyday ailment. And in far too many cases, the patient reaches a surgeon only after paralysis is complete and all hope for restoration of function has vanished. I think we've all been here, especially as residents. We get called, 2 a.m. that, patient's been here for 2 or 3 days. They finally got an MRI. By the time you see them, they're either quadriplegic and paraplegic from the epidural abscess. They're 48 hours out and there's not much that can be done. And sadly, this is published in 1948. I would say that we still have this issue where this illness is often routinely mistaken for some everyday ailment. And I'm going to get into a little bit why that's happened and kind of stress the kind of neurological findings we should look at to try to avoid this, to hopefully, instruct our internal medicine colleagues and ER colleagues. So in terms of, how to achieve an accurate diagnosis, you have to have a good history and physical, appropriate ordering of laboratory tests, and, obviously utilization of the imaging studies that they didn't have back in 1948. So in terms of the manifestations of vertebral osteomyelitis, often, like Dr. Huesner mentioned in 1948, they can be vague symptoms. So it could be just back pain or neck pain, often worse at night, that can be confused for a degenerative pathology. Pain is definitely the most common symptom, presenting in up to 86% of patients. Patients with cervical vertebral osteomyelitis can also present with dysphagia or torticollis, and fevers may be present in up to 35 to 60% of patients as well. In terms of the clinical manifestations of spinal epidural abscess, again, this is from Huesner's landmark paper in 1948. He described 4 phases or stages of spinal epidural abscess in terms of how patients can progress if they're not caught in time. So typically patients initially present with, what he called spinal ache or pain, obviously, just back or neck pain or thoracic pain, which can then progress to root pain. So patients then start complaining of, radicular pain down the arm or down the leg. And then eventually this can progress to sensory loss and then weakness, and then ultimately paralysis if it goes ignored for too long. And, once neurological dysfunction is present, the average time to complete paralysis can be as fast as 24 hours. So we really don't have a lot of time to intervene if a clinical suspicion is there. So next, I want to go into the laboratory findings. I think this is super important, especially for patients that start antibiotic treatment. So in terms of laboratory findings associated with osteomyelitis and epidural abscess, I would say leukocytosis is present in only approximately half of patients. It's actually ESR and CRP, which just serve as a more useful marker of inflammation. And they have reported sensitivities of 100 to 98%. CRP, interestingly, has been the only demonstrated factor to shorten the diagnostic delay of vertebral osteomyelitis in the era of modern imaging, which I found interesting and which I did not know. And that CRP also serves as a more useful monitor of treatment response, as it has a shorter normalization time than ESR. So if we ever see these patients back in the ER and, the ER is calling, hey, they're back with back pain, in addition to getting, imaging studies, I think it's also useful to get these laboratory markers to evaluate their progression of disease or whether or not they're clinically improving. In terms of other laboratory findings, blood cultures also may be positive in the setting of active spinal infections. So it's also prudent to obtain blood cultures in these patients. Locker et al. Published their series of 253 patients in 7 Cleveland area hospitals. And they found that blood cultures to be positive in approximately 30 to 50% of cases. So next, I want to go to diagnostic imaging and its utility. So, back in 1948, all they really had was plain radiographs. And, this is all you could really see. You could see in this image some end plate destruction, erosion, but, you had no real way of visualizing the spinal canal. You had no real way of visualizing the bony elements in greater detail. But now with greater imaging quality, we can actually diagnose these patients a lot easier. So, plain radiographs still have utility. However, they're important for demonstrating overall alignment of the patient, and also any mechanical instability that could develop from osteomyelitis, discitis. And in terms of the utility of this imaging study, it's important to know that initially these patients may have normal radiographs in the first couple of weeks of their disease. Again, like I mentioned, the earliest changes are typically, end plate erosion, the loss of disc height, soft tissue swelling. So again, radiographs, can be helpful, but early on in disease, probably not the most helpful thing to order. CT, however, can be super helpful, especially given the fact that it can, in greater detail, look at the end plates and demonstrate any lytic lesions or gas within the disc space. However, for spinal epidural abscess, CT isn't obviously a great way to image and diagnose those patients. So again, MRI, definitely the gold standard, and it remains the imaging modality of choice. It's been published that it has a sensitivity and specificity of 96 and 94% respectively for diagnosing osteomyelitis and epidural abscess. So I would tell our colleagues, if there is a strong clinical suspicion, MRI is definitely the way to go. Obviously, many of you guys know the classic MRI findings, but just for thoroughness and for the junior residents, on T1, you can see low signal from the vertebral body in the disc space and decreased signal intensity across the vertebral body. And on T2, we typically see increased signal intensity from the involved vertebral body and disc space. I'm not going to really discuss tuberculosis spondylitis because that's a whole different topic that it can be a whole different lecture. But I also just wanted to point out that MRI can be also helpful in distinguishing pyogenic spondylodiscitis from tuberculous spondylodiscitis, and that's mainly because tuberculosis relatively spares the intervertebral disc while causing massive destruction to the vertebral bodies involved. And here's this case example that I wanted to bring up. So, for our colleagues, I think this is a good diagnostic algorithm for confirming the diagnosis of any patient with suspected spondylodiscitis or epidural abscess. So first, very important to get a good history and physical exam, and this cannot be overstated. I think oftentimes we rely too much on imaging, but I think first and foremost, get a good history and physical, see if the patient has any neurological deficit, order those laboratory markers that we described, get an ESR, CRP, order blood cultures, definitely before administering any antibiotics. And then in terms of advanced diagnostic imaging, you can always start with a conventional radiograph. No one's going to fault you for that. But, gold standard is definitely MRI. And once you confirm diagnosis, you can then go on to the next steps. So now on to the next step. So I first want to discuss conservative treatment and its controversies as well as surgical treatment thereafter. So in terms of conservative treatment, antibiotics have now become the gold standard of treatment in patients, obviously with no significant neurological deficit and no significant deformity or bony lysis. Here was an interesting study done in 2015 by a group in France. They did a randomized control study looking at 6 weeks versus 12 weeks in patients with pyogenic vertebral osteomyelitis. This was an open label study, and they found that there was essentially no difference in overall outcome between patients who were treated for 6 weeks versus 12 weeks. This then prompted these guidelines to be published in 2015 by the Society of America of Infectious Disease, and they recommended a total duration of 6 weeks of parenteral or highly bioavailable oral antimicrobial therapy for most patients with bacterial spondylodiscitis. And I think this is what we do here at Jackson as well. So in terms of this controversial topic, I think this was interesting. So I think, we're definitely taught that you have to hold antibiotic therapy before you do any disc sampling. If your blood cultures are negative, you need to identify an organism. You definitely want to hold antibiotics before you biopsy the disc. It's interesting, however, that the evidence behind that is not great. There was a group by Johannes Marshall published in 2011. They looked at the impact of pre-biopsy antibiotics on pathogen recovery in hematogenous retrieval osteomyelitis. And you can see, in the results, open biopsy predicted positive biopsy culture results. They found that there was no association of pre-biopsy antibiotics with culture results, indicating that giving antibiotics preoperatively did not make a huge difference. I mean, again, this is just one paper, but I think, this kind of these guidelines that we follow aren't all necessarily backed up by a ton of evidence. So even if you do give antibiotics before, I still think it's obviously worth doing a biopsy of the disc space or the bone if you don't have a pathogen. So in terms of evaluating treatment response, again, like I mentioned, CRP tends to respond a lot faster than ESR. So that's an important laboratory marker to follow if you are following these patients. Obviously, your infectious disease doctors are often the ones doing this. In terms of ordering, repeat MRIs, surveillance MRIs, that's definitely something that, I think we as neurosurgeons will recommend. And even the infectious disease doctors have also realized that MRI surveillance can be misleading. And now there's actually a strong recommendation in the treatment guidelines against its use to assess treatment response. Because it's interesting, radiologically, healed discitis usually presents with vertebral body fusion due to destruction of the end plate and exposure of the cancellous bone, like we see in these three slides. Here we see this patient with vertebral osteomyelitis discitis, and then we see the progression of disease, and then he ultimately fuses. This is at I believe at 1 year out. So I think it's, a little foolhardy just to repeat MRI images, use your inflammatory markers to evaluate treatment response. In terms of spinal epidural abscess, again, we've come a far way in terms of our advancements with antimicrobial therapy. This was an interesting table published by Huesner. He collected all these case series of spinal epidural abscess before 1927. The percentage of deaths was 92%, which is astounding. And then you see that number drop. Again, we see the cases collected before 1937. The death rate went down to 60%, and then went even plummeted down to 31%. And then finally, we see Boston City Hospital, the death rate was 22%. And this was a series from 1930 to 1948. And this is definitely the result of the introduction of, penicillin and streptomycin, which, revolutionized therapy. It's interesting at that time, in addition to antibiotics, obviously fusion was not something that had been really developed. Pedicle instrumentation, ACDF plates, lateral mass screws were not around. So patients were put on antibiotics and then rested on a frame or plaster bed, and were essentially, casted for long periods and were put on bed rest while being on these antibiotics. So in terms of antibiotic treatment for spinal epidural abscess, in terms of the indications, if it's caught early and patients don't have any sort of neurological deficit, it's definitely reasonable to start off with antibiotics. I think that's number one. Number two, if a patient has had a complete neurological deficit longer than 48 to 72 hours, some would also say it's probably foolhardy to try to do a laminectomy. Antibiotics should be sufficient. Some also would argue that patients with holochord spinal epidural abscesses that extend from the cervical, thoracic, lumbar spine may also, this benefit from antibiotics. But I think, the first and foremost, the patients that should be getting antibiotics for spinal epidural abscess are those that are caught early with no cord compression and with no neurological deficits. In terms of the risk factors in terms of failure of medical therapy, I think this is also important to know and realize. if we do sign these patients up for antibiotic treatment, if we tell the infectious disease doctors, we're not going to operate because there's, no significant canal compromise, cord compression, etc., it's important to, follow these patients or, check in on them, because patients with diabetes, MRSA infection, obviously neurological impairment, or age greater than 65, all these factors together, their risk of failure can be as high as 77%. So I think this is also important to realize and know in terms of following these patients in the long run. Now, in terms of the role of immobilization, which I mean, not instrumenting them, using either, just a TLSO brace or LSO brace in addition to antibiotics. There is a role for this. And I think, you just have to be careful who you sign up for this type of conservative management. Obviously, it can't be someone with a significant kyphotic deformity. It can't be someone with a lot of bony lytic destruction in their spine or mobility on flexion extension x-rays. It really has to be reserved for a specific cohort of patients. This was a study published by the Spine Journal in 2014. They looked at rigid spinal bracing versus percutaneous instrumentation and a soft brace for patients with osteomyelitis. And they actually found no significant difference in infection resolution or healing times comparing these two patient groups. However, you can see in their figure 3, in terms of the visual analog pain scores, their pain obviously in the surgery group improved a lot faster from at diagnosis to 1 month. You can see that the significant difference at 1 month and 3 months, and then these two kind of balance out at 9 months. But, it's important to realize that this can be a treatment option in a carefully selected patient group. So again, factors predictive of treatment failure. This is important to know if you're going to sign someone up for conservative measures. And like we mentioned, patients with extreme age, diabetes, poor general health, low socioeconomic status, and obviously patients with instability on x-ray, advanced bony destruction. These patients, you have to be hesitant to sign up for conservative measures if your, internal medicine doctors consult you. Now let's go into surgical treatment. This is, I think, where more controversy arises. So surgical intervention is, typically indicated in situations of, failed or inadequate tissue sampling. Obviously, in patients with severe neurological deficit, surgery is obviously indicated. Patients with severe spinal canal compromise or epidural component, and like we mentioned, patients with instability, and patients obviously who've undergone, at least 6 weeks of treatment, have failed treatment, and have persistent pain or symptoms. So this, I think, is important take-home message when you're first getting called about that consult. The infectious disease doctors are pushing you for surgery, but it's important to know what the actual indications are. And I think this, this table in itself is super helpful. I wish I had it as a junior resident to kind of look at. Heron in group, they published 3 additional measures to look at in terms of what could help push you to intervene surgically. And those are patients with, segmental kyphosis greater than 15 degrees, vertebral body collapse greater than 50%, and any translation greater than 5 millimeters for instability. So again, this I think is also helpful in terms of helping you decide, pushing you one way or the other, whether or not a patient is a surgical candidate. Now, in terms of the surgical options, I think this is where more controversy arises. You have, multiple options. They can include something basic as debridement and decompression, just laminectomy and drainage of the abscess. And then as we progress, if there is deformity developing, stabilization or infusion, and obviously deformity correction. And these goals can be achieved through different methods, and this is where the controversy arises, through either anterior, posterior, lateral, combined approaches, or even through minimally invasive techniques. So I think for a lot of surgeons, it has to do with, with where they trained and their preference and what they're comfortable doing. And, obviously the approach of surgery depends on the level of the pathology and the part of the vertebra that's involved. Here we see a systematic review published by Alexander Vaccaro. This is a list of 10 studies or so published in the last 5 years, kind of going over the surgical approach that these surgeons used for spondylolisthesis. And here we can see some surgeons used just a single anterior approach, combined approach, just a posterior approach. And, the question is, what's the right answer? And I think the right answer really depends on what part of the spine you're operating on. So based on what I've kind of gleaned from the literature, this is what I came up with. So in the cervical spine, I think an anterior approach is typically recommended, especially if there's, a ventral epidural component compressing the spinal cord. Direct decompression is always best. And you can, achieve a gross decompression of the spinal cord with discectomy and or corpectomy, and then at the same time use a bone graft or a piece of fibula and use an anterior plate to stabilize it. Eventually, if the involvement was mainly epidural with no destruction of the vertebral body, then it's definitely also acceptable to proceed with a posterior decompression infusion. In the thoracic spine, as we all know, stability is maintained mostly by the rib cage, and physiologically that obviously restricts mobility, and stability issues typically aren't a significant priority here. So therefore, I think in the thoracic spine, presence of an epidural abscess and bony involvement, if there isn't severe kyphosis, I think a posterior approach with decompression instrumentation is usually the first option. Some have explored the role of thoracoscopic spinal surgery in the management of pyogenic vertebral osteomyelitis, which I thought was interesting, which is why I included this study. This is a group in 2004 that published essentially a thoracoscopic approach for monosegmental lesions in the thoracic spine to essentially reconstruct the anterior column, essentially demonstrating the feasibility and efficacy of this approach. But then you have to question to yourself, is it worth, the blood loss, the operative time, and the risk from going anteriorly? And then finally, in the lumbar spine. So I think in the lumbar spine, thoracolumbar junction, decompression and stabilization are definitely recommended in the presence of neurological deficit or epidural invasion. And I think in cases with moderate anterior bone involvement and minimal kyphosis, a posterior lumbar interbody fusion should be sufficient. It's interesting. I found this study. This was a study that included 78 cases published in 2006. And the authors noted that they had 23 patients with again, spondylolisthesis that were initially scheduled for a secondary ventral debridement. They initially backed them up dorsally. They did dorsal laminectomy and fusion, and then found that these patients actually autofuse on their own and actually did not require the second stage or ventral surgery, debridement surgery, kind of suggesting to me that dorsal instrumentation and decompression can oftentimes be more than enough to treat these patients. In terms of anterior stabilization, so I think, especially in the orthopedic literature, anterior stabilization is definitely, I think, advocated more in these patients. The authors of these studies, they typically, they argue that patients with, monosegmental spondylolisthesis with minor kyphosis, that just anterior fusion alone with the bone graft can be considered and can actually sufficiently stabilize the patient. This was actually an interesting study published in 2007 in an orthopedic journal. This kind of looks at the long-term results comparing ventral instrumentation versus ventral dorsal, so front back surgery in the treatment of spondylitis. And they found that patients with who had undergone exclusively ventral fusion felt significantly better and experienced less pain in the area of the spinal fusion than patients with ventral dorsal fusion at 2 and 5 years after the operation. And they found that their fusion rates were identical. So, some argue that anterior stabilization is better. Again, some argue posterior stabilization is better. The one thing that I know at our institution, I've definitely seen are both approaches used. One thing to keep in mind, however, is that anytime you go do an A-lift, go from the front, you should always be wary that anytime there's an active infection, often the pelvic vessels, the great vessels, the iliac arteries and veins are often adherent to the disc space due to inflammation. So you realize you're also taking up upfront greater risks if you are planning on anterior instrumentation for these patients. And I just think that's something that can push you one way or the other, depending on who your approach surgeon is. Obviously, if you have Dr. Abdullah, who's more experienced, you may be more comfortable going from the front. However, if you have someone who you're not more comfortable with, and dorsal fixation and decompression may be your better option. Here's just, another paper demonstrating that posterior lumbar arteriovalve fusion with autogenous iliac crest can be very successful. They looked at 18 patients, again, demonstrating that going from the back is more than enough in many of these patients. So lastly, is a combined approach ever warranted? I think, only based on the literature that I reviewed, only in select patients. So, as we all know, purely dorsal stabilization at the thoracolumbar lumbar spine essentially produces load shifts from the anterior spine onto the posteriorly situated implant. And in patients with large ventral bony defects and destruction from infection, that bending load can result in kyphosis and, in extreme cases, material fatigue and rod or screw breakage. So I think additional anterior stabilization is really only indicated in patients with very large anterior substant defects, where this 360-degree fusion is truly only warranted. Now more recently, in terms of recent advances in surgical treatment, we've seen a push towards OLIF procedures or lateral procedures. These are two papers I found, one from our own group with Karthik and Dr. Vanni. They published their series in 2014 of direct lateral retroperitoneal approach for one monosegmental disease. And then here we see a publication in 2021 describing the OLIF as another possible surgical corridor to treat these patients. And the argument obviously is this is more minimally invasive and patients can go home sooner and recover faster. In addition to these approaches, full endoscopic discectomy has also been advocated. This was a paper published in 2019. They looked at a series of elderly high-risk patients with spondylolisthesis, and they found that patients without severe deformity, again, especially the elderly or debilitated, can benefit significantly from these conventional surgical approaches. Typically, you can do this awake, without general anesthesia, and you can actually debride and drain the abscess and actually relieve the patient's symptoms. Next, I briefly just want to touch on grafts in the setting of an infection. I think the mindset from at least, the past, 20 years ago was always to use, cancellous iliac autograft or allograft for these patients, just to reduce the risk of, recurrent infection. However, I think, with more and more studies coming out demonstrating that titanium is actually safe to use in these patients, we may see the use of titanium increase more and more. This was just an interesting study looking at the use of titanium mesh cages in the reconstruction of anterior columns, in the reconstruction of anterior column defects, essentially demonstrating that in spite of theoretical risk, titanium cages are a suitable alternative treatment to autologous tricortical iliac crest bone graft in patients with active spinal infections. Finally, indications for spinal epidural abscess. I think, again, for the juniors, any patients with acute or progressive neurological deficit obviously have to go to the OR. Any patients with spinal deformity or instability, disease progression despite antibiotic therapy, and patients with cervical and thoracic spine epidural abscesses, if you're not going to operate on them, follow them closely because they can progress to cord compression. This was just a nice review published by a group from the USC neurosurgical department, kind of looking at the indications and timing for operative management of spinal epidural abscess. So in addition to these indications, I think they highlight these other risk factors in terms of pushing you one way or the other. And we've kind of talked about some of these. So like patients with diabetes, MRSA, active or progressive motor deficits, bacteremia. they argued may require urgent operative intervention, especially if they have one of these risk factors. Now, one of the last few topics I want to discuss is just timing. So in terms of timing and the surgical evacuation of spinal epidural abscess, there's not a lot out in the literature. This again was published in 2014 by Dr. Harrop's group at Jefferson. They essentially looked at patients who are intervened on less than 24 hours and greater than 24 hours after surgery. And, I think what was interesting about this study is they found that evacuation within 24 hours appeared to have a relative advantage over delayed surgery with regard to discharge neurological grade. However, a significant benefit could not be shown. So as we see here, patients with surgery within 24 hours, this is their presenting AS grade and their AS grade and discharge. As you can see, the grading before and after 24 hours, their grading scores actually did not significantly change. So, this tells me though, however, even if a patient presents greater than 24 hours after presentation, you should still intervene. Greater than 48 to 72 hours, it may be fruitless, but obviously this does suggest there is some marginal benefit even intervening in the middle of the night if the patient presents at that time. So in terms of the surgical approach for spinal epidural abscesses specifically, so in terms of ventral spinal epidural abscesses, obviously going from the front, especially in the cervical spine, is obviously more beneficial as you can decompress the spinal cord directly. In terms of dorsal abscesses not associated with osteomyelitis, laminectomy alone can be more than sufficient. And oftentimes these patients don't require any instrumentation, and all the purulent material can be removed using suction irrigation. And then, patients with more chronic abscesses, there may be a significant amount of granulation that's often inherent to the dura. So you just have to be cognizant of that and be more careful when dissecting that off. One of the last few things I want to talk about is surgery for holospinal epidural abscesses. These are quite rare. So these are epidural abscesses that go from the cervical down to the lumbar spine, whole spinal abscess. And if you do ever come across this, I found a few technical notes that I thought were interesting. This was actually published by Reg Hayes Group back in 2001. And they talk about doing skip laminectomies over the areas of compression and using a Fogarty catheter through the epidural space, essentially going from the caudal laminectomy side to the rostral one, and then essentially inflating 1 to 1.5 cc's of saline to remove the purulent material. Now, finally, just want to discuss outcomes. In terms of vertebral osteomyelitis, it continues to be a devastating disease and a disease difficult to manage. However, we have our rates of mortality have improved tremendously since the 1920s, from 92% to now as low as 3.6%. Again, it's important to know that patients, if you do sign them up for conservative measures, what risk factors to be aware of in terms of which patients can fail and may need operative intervention in the future. And finally, in terms of spinal epidural abscess, again, we've also come a tremendous way, from mortality rates as high as, 40% in the 1950s to now 3.2%. This is just, again, from Huesner's publication, just looking at the effect of penicillin and sulfonamides upon mortality in Boston City Hospital. And you can just see the survivals before and after the introduction of antibiotics. This continues to be a difficult disease to manage. It's important to diagnose early. And unfortunately, the frequency of poor outcomes continues to be high, just given the delay in diagnosis in a lot of these cases. And patients may continue to have, issues with paraplegia, bed confinement, as high as even 40%, even in the current literature. So hopefully, we went over all these topics slowly enough for you to absorb all that information. In conclusion, this is just obviously spondylolisthesis is, a very serious disease that continues to be very challenging for spine surgeons. I think there still needs to be there still continues to be a lot of controversy, and I think we definitely need more data in terms of understanding what surgical approaches are best. I think it all depends on where the disease is, where the bony destruction lies, and I think we will continue to grow and learn as we kind of push the boundaries with more minimally invasive approaches as well. Anyway, thank you for your time. I hope you guys have a great rest of your day. Good luck with surgery.
Great job, Arya. Just wanted to make one comment. I definitely would emphasize the fact that this is whether these patients end up having surgery or treated conservatively with IV antibiotics, they're often devastated in the sense that it's usually like a 6 months to a year process for them to get fully better. They suffer from severe pain often. Even the ones that are successfully treated have pain for a long time. And there is a small subset of patients, but we see them is that they get their antibiotics, they don't have surgery early, but they still have terrible pain. And they're not actually fused on CT, which is typically one of the guides to say that the infection's been successfully treated. So a few of them end up with late surgery for chronic pain or instability. And we just took care of a guy from South America with, his infection at L5S1 was cured. His CRP and his ESR was normal, but he was highly unstable at that level. So just a point, like when you're talking to these patients, it's important to sort of put a perspective that this is, you have a little infection and it's going to get better on antibiotics pretty quickly. They take a long time to heal with or without surgery.
Right. No, that's a great point. Thanks, Dr. Levy. Yeah, I was like reading the literature, and yeah, they were saying it can take up to a year for them to autofuse on their own. So they could potentially be debilitated up until that time. So no, that's important to remember to discuss with these patients that they may need surgery down the line, even if antibiotics help somewhat. Okay, awesome. Well, if there are no other questions, I hope everyone has a great rest of their day.